esophageal and gastric cancer. So esophageal cancer, it's not very common, less than 1% of all cancers, but boy, it's terrible because it's a very high mortality. It's 3% of cancer deaths. A third of the patients present with locally advanced or metastatic disease because they're quite innocuous. You know, dysphagia, you eat spicy food, your administrator always gives you problem, you have an upset stomach, hyperacidity, you get prone to GERD, reflux, and so you have this. The risk factors are, again, I keep telling you, tobacco cessation program. It's one of the best, most effective prevention programs. It's preventive, you know, no smoking, no cancer. Alcohol, minimize alcohol, and of course lower socioeconomic state. It's paradoxic that if they do analysis, the families who are in lower socioeconomic state spend a larger percentage of their income on the smoking and alcohol. Actually, it's actually a terrible situation. It's a male predominant, and there's rising incident in adenocarcinoma of the esophagus, GERD. So the staging system, it's TNM and grade, TNMG staging. That's what we use. There are different staging systems for squamous and adeno, and squamous is worse. The key points is that they have changed the descriptors to T1A and T1B. This is based on endoscopic, then histologic findings. T1A, you'll have this in a copy. It's a nice picture. A is the mucosa, right under the mucosa. B, it's into the submucosa. T4 is A and B. The A means it could be resected by the very brave surgeons we have. Some of our surgeons are really very able to do multidisciplinary surgery. That is, we have abdominal and chest surgeons doing the same thing. If there's invasion of the pleura, they will decorticate pericardium, remove the pericardium and replace it, or diaphragm, they will remove the diaphragm and replace it. T4B, adjacent organs would be like the aorta, things like that. It may be too long to reset. M descriptor is the number of nodes and region. So 1 to 2, 3 to 6, greater than 6 lymph node metastasis is N1 to 3. And it has to be local, like the adjacent sites. Okay? M1 means non-regional. M1 means if you have like a lower esophageal, you have a supraclavicular node, that's non-regional. Or you have a lower esophageal and it's past the celiac axis. At the celiac axis, it becomes distant metastasis. Okay? And any other organ. And it can go to any organ. Liver, lung, you name it, brain. That's why it's so aggressive. This is a nice summary, because if it's confined to T1A and B, mucosa and submucosa, you can do just surgery. They can either do endoscopic, they can peel it off, or they can irradiate locally, or they can do esophagectomy, take it out. If it's T2 to T4A, if it goes beyond the serosa, past the muscularis propria, then you can still do multimodality. They do chemo, then chemoradiation, and then you reassess if it's amenable to surgery, because the only patients who do well after esophagectomy are the patients whose resection specimen had shown nearly complete necrosis, complete removal of cells which are alive. So T4B you do not resect, these are unresectable. They usually involve the vital organs, the heart itself, the aorta, creeping up around the aorta. We use 3 imaging modalities always in tandem. This is TNM. T staging, endoscopic guided gastroduodenoscopy. You do the scopum, and then you do ultrasound and do the biopsy. But prior to doing this, we do the diagnostic CT scan and the FDG PET-CT. Because the CT and the PET-CT will identify not only the primary, where they can have to assess how deep it is, T1, T2, T3, T4. It will tell us where they can be on the lookout for lymph nodes adjacent to the esophagus. Okay? And the PET allows them to be able to see sub-cm or small nodes which may be FDG avid, so they can get them. There are some nodes which are big, non-FDG avid, but you can see them on the CT. They might have sometimes necrosis, so you use both. So the FDG PET-CT and the diagnostic CT is the map, and then the endoscopic ultrasound will be the biopsy site. And then after therapy, we repeat everything again. And on surveillance, depending on the symptoms, we can do either all or a few of them. So this is just an example for T status. You can see it's all hot if you just have FDG PET imaging. That's likely the primary, it's going around. You can tell if it's involving the aorta. But if you do a good contrast enhanced CT scan, you see it's the arterial phase. You can see it's kind of wrapping around. There's this soft tissue, abnormal soft tissue thickening. So there's this primary circumferential thickening of the mid-esophagus, which we have the heart. And there's the soft tissue extension around the aorta. It's slightly unresectable. So they confirmed this at surgery that the tumor at attempted esophagectomy was there. And again, every patient is different. You have to assess. Younger patients may need more aggressive therapy. Older, infirm patients may not get as much therapy. Or if they have things like this where they are very symptomatic, they need to put a stent in because they have compromise of the aerodigestive tract and the airway. They are forced to go to surgery. Nodal status. Again, 2, 6, greater than 6. Greater than 1 cm short axis. This is the one we already have to be very careful of. You have to know kind of like the pattern of where these nodes are. The other pattern we're very used to lung would be paratracheal. Here you have to be aware of the more proximal and more distant paraesophageal lymph nodes. They could be small. You have to know the pattern because they could be difficult to assess with CT alone. So if you're unsure and the nodes are big, greater than 1 cm short axis, looks like a coffee bean. Short axis, you have to measure. If they are local nodes, then the endoscopist will biopsy them because they would look malignant on ultrasound, so they know how to biopsy. These are the nodes you look at. They are commonly lower esophageal primaries. I see the lower paraesophageal nodes, the paracardiac nodes. Celiac nodes are distant. Anything lower than this is considered distant disease or supraclavicular. If the primary is proximal, then these are your local nodes, the paratracheal, upper paratracheal. If it's mid-esophageal, you can have the subcarinal and middle paraesophageals. So it's local, regional, and then anything which skips is considered distant metastatic disease. It is important to actually assess the nodes so our radiation oncologists know what to treat to extend the field. And so that's what usually happens. It's very important. The problem with PET for N status, it's not that sensitive. Its specificity is slightly better than CT, but sensitivity, because it's insensitive to small volume micrometastasis. And then this could be adenocarcinoma. If you look on the histology, the cells are very fat. It has a lot of cytoplasm, but the nuclei are pushed to the side. So the volume of the nuclei is very small. So the surgeon has to be alerted to nodes which are potentially outside the local regional field or the radiation oncologist. The problem is it's difficult to see them locally, but you have to be very careful because primary here, and you have the adjacent. This is a lymph node. So these are local nodes, so they can biopsy them. You have to be alert to them. The problem with FDG, if you don't do it with contrast, is all hot. It's trying to find the chocolate chip in a chocolate muffin. You know, that it's all chocolate. So you can't find the chocolate inside the chocolate muffin on the outside. You can't see what's inside. That's how I think of it, chocolate. And then if you do a well-done arterial phase contrast enhanced CT, make sure you can do the coronal and sagittal reformat. The coronal reformats are very helpful because you can see this the left gastric nodes, you can see them very well. You can see subcarinal adenopathy, you can see here. They're not very big, but these are always very concerning. If you alert them, they will biopsy them. Because if you're in doubt, you need to biopsy. Anything, particularly if they're outside the locoregional, particularly in the celiac, or if they're supraclavicular, you can do an ultrasound and do the biopsy. These are examples of non-avid. Lower esophageal, this is just a bit of the heart. This is non-avid node. See, left gastric paraesophageal node. Sorry. And this was mucinous adenocarcinoma. They were positive. But we alerted them to it because we know they're slightly more bigger. So you have to have an element of experience when you're reading through it. You have to be quite thorough and also look at the sagittal so you can see, you can give a measurement approximately where the tumor begins, because sometimes they could have a skip. These are FDG avid sub-centimeter. You can have very small nodes which are positive. They would be considered benign on the CT, but if they're FDG avid, they gotta be aware that they're there. If they could reach them, they would biopsy it. If not, they may sometimes assume they're part of the disease because they would get chemo. And then at the end of chemo and radiation therapy, they might include them. You see if they become smaller or lose their FDG avidity. Meta-analysis, multiple studies, it's kind of old. Again, sensitivity 51%, specificity 84. If it's positive, you're okay. It's negative, you try to go by size criteria so you can biopsy. Distance PET is king, FDG. It can identify distant visceral metastasis. In up to a third of patients, when they think they're resectable, up to a third of them will be unresectable after you do PET scans. Primary would be the lungs. The lungs, you have to be careful because, we're breathing. So small volume disease will have very little FDG activity, and they could be blurred out. So you have to look at the CT study to make sure there are no suspicious nodules there. That's where you usually miss them. Bones, we can see them. Adrenal glands, if they become, usually they're FDG. And it's the lungs where we tend to gloss over them sometimes. Its superiority for detection distant disease is much better. Obviously, EUS you can't reach everywhere. Up to 20% may or may not be resectable. May be unresectable depending on the series. It's between 20 or 30. This is from the German group, but Wolfgang is now in Sloan Kettering. He's the chief there, so he's moved back to the US. So this is what we have to remember. You're dealing with a tumor where lymphatic and hematogenous metastasis can occur early. So they could be systemic disease. So it's very rare to encounter a surgically resectable one. Those we find by accident. They have a checkup. They're doing endoscopy for gastroesophageal reflux, and they find a lesion. They biopsy it. It turns out positive. T1A, T1, T2. Those are the ones. You can have skip nodal metastasis, 10-20%. That is, you can have distant nodal disease in these patients. Hematogenous metastasis in a third of the patient, because then you can have liver mets, soft tissue mets, lung mets. Hematogenous and peritoneal metastasis are occult on CT imaging. So you have an FDG. This is the primary proximal extending to the gastric proximal stomach. CT scan, even done with contrast, has nothing, but on the FDG study, you have very clearly metastatic lesion. You might see it on the MR probably, but if you're doing contrast-enhanced CT, not a multiphasic study, you might miss it. So integrated PET CT, and again, can show you, early on, we didn't realize. At first, we thought esophageal, has no serosa, you can follow it, and local nodes maybe, etc. But we didn't realize it has distant organ metastasis. This is an old study we did, 300 patients. 7% had unusual locations. So this is a patient with widely metastatic disease on CT. All of the lesions are there. Can you see these 7 or so lesions? But you can see that they're there, and when you go back, and then you try to go back, you can see that maybe this is a little bit of a bulge here, and back again. And then you see maybe there's slightly more attenuation here. So in the CT, you will miss a lot. So you have to have FDG as part of the study. It's widely metastatic disease, but you have a hard time finding these small lesions on the CT. So this is just to convince you, none of the patients who have esophageal cancer will ever be treated unless they have a PET CT study. M staging is done with the FDG. You cannot have an assessment of metastatic disease without an FDG PET scan because you will miss them on the CT scan. And that we learned the hard way. It's like our chief of thoracic surgery. One day I was speaking to him, former chief, Reggie Munden. He is the chief at Methodist Hospital now. I said, Reggie, why are you look so sad? He said, I've been reading chest CT scans for esophageal cancer for 2 decades. Now we just wrote this paper on FDG. How many thousands of patients did I miss those metastatic lesions? Because you don't even see them, and then suddenly they light up like the Rockefeller Christmas tree. So that's the problem. So it is a given that you need to do it. If you look at all the one of the first studies where one of the first NCCN guideline recommendations was actually for esophageal. And they did not recommend PET. They wanted PET CT because it can localize. So differentiation is also important. Poorly differentiated are classified differently, as well as undifferentiated, because they do perform more poorly, these patients. So again, this is just to emphasize hematogenous and peritoneal metastasis are occult on staging. So assessing response, you assess M disease, you know where to put the fields, you repeat the PET scan. Why? Because there is a reason. Is the patients who have complete pathologic response, so we try to use PET imaging to try to see, can we predict pathologic response, because it does predict prolonged survival. That is when they take out the esophagus. Long-term survival tend to be those who have complete pathologic response. They have any residual viable tumor, no matter what else we find, they have a poor outcome. Typically, you have a distal esophageal, you have a left gastric node, and when you treat them, it's all gone. Those early reports show that there's a reduction that correlates highly. It's not 100%, but a reduction of activity correlates with a likely pathologic response, but it's not a one-to-one correspondence in terms of completeness of response. We have the Belgian group, we have the German group, and then another separate German group is published extensively on this. What is our experience in the patients who have this? You have to read it knowing they get radiation therapy. So if a patient has residual activity in the radiated esophagus, you can't tell. You have to have the endoscopist do a biopsy there to distinguish between post-treatment inflammation or residual disease. You can see here, this is a residual thickening. It's still thick, distal esophagus, FDG avid, high SUV, no esophagitis, no ulceration. This is residual tumor. This is at esophagectomy, 50% viable tumor. Okay, so you have to make sure you have to still use endoscopic ultrasound to do a biopsy. Interval metastasis is important. We do a PET scan prior to esophagectomy because despite chemoradiation, they will develop metastasis outside the treated field. It could be as low as 8%, it could be as high as 15%. But let's say a round number for us is 1 out of 10 would have interval metastasis, so it would be futile surgery to do esophagectomy. This is a very long, complex procedure, and only very healthy patients can do this, so you want to choose your patients well. So for us, in our series, we detected 8%. They could be in the liver, non-regional nodes, could be bone, skeletal muscle, could be lungs, could be anywhere. This is after chemoradiotherapy. You see a solitary spot, right, prior to surgery. It's a solitary lytic metastatic lesion in the left scapula. So this is systemic disease. A larger series, we did 151 patients. Again, reduction of SUV is a good prognosticator, but still it's not a perfect test. And so if there's a reduction, it usually tends to portend that these patients would do well. For us, not only does it do well, but it makes sure that these candidates are suitable candidates for subsequent esophagectomy. This is the survival plot on these patients. Those who have a reduction in FDG activity tend to do better. The more recent study we did was after a single cycle. We can only do so many of this because Medicare does usually pay for extra imaging. So you can get one at baseline, end of neoadjuvant therapy. This one was the end after a cycle of chemoradiation. So again, it's hard to predict, but if they have high FDG activity volume, they tend to do worse. High volume FDG avid disease tends to do worse. It's very difficult to find the association again, because when you give chemoradiation, there's a normal inflammatory response in the esophagus. So it's hard to really predict. So in the end, what is it useful for? Those who have very high volume disease and show very rapid reduction or very high reduction in FDG activity may do better than those who do not show this rapid reduction. But if it's very high, no matter what you do, the high volume, they usually do not do that. These are just what we do for patients. Neoadjuvant chemoradiation is the standard, followed by esophagectomy. That's the standard. Survival benefit from esophagectomy happens if they have this complete response. I'm just summarizing what we have to do. An FDG PET can identify the responders to neoadjuvant therapy when performed after a couple of cycles of induction therapy. That's what we did, 2 cycles. So this is a pattern of recurrence. Patterns of recurrence are this. You have to do this. They have an Ivor-Lewis esophagectomy. And on the CT scan, you already see the problem. There's this nodular thickening, which you can see here. It is confirmed by the FDG activity. The FDG activity is good because it tells you that it may just be a localized recurrence. Liver looks okay, spleen, there are no bone lesions. And then you send the GI Joe in, and the patient has candidiasis, but they biopsy the site of recurrence. So that's how you evaluate it. This is inflammation. They put a stent in to keep the esophagus open. These areas of activity, it's impossible to tell. If it's tumor or inflammation, it's usually inflammation combined with tumor because it's pressing the tumor out of the way. This just to keep the esophagus open. So these are the things you have to deal with when dealing with esophageal cancer. Complications of therapy. This is the baseline study after Ivor Lewis esophagectomy. We like to use these calcified clips as landmarks. They come back, you can see there's now greater tissue infiltrating around this transhiatal esophagectomy and gastric pull-up, and it's all FDG avid. This is local tumor recurrence. So this is what happens. So, and this happens when they get more symptoms and they follow up every 3 or 6 months. Chemotherapy can be complicated by fistula formation. The maintenance of nutritional needs is critical. They all have gastrostomy tubes. There is need to reduce the treatment-related morbidity. We try to avoid doing esophagectomies as much as we can, because the patients tend to not do well after they had an esophagectomy unless they're very strong, very healthy, and they have an unusually nice post-operative course, because a lot of them can get anastomotic leaks. This is gastric juice, acid. You know, it can melt stuff, and it regurgitates, and you drink all of this stuff and eat all of this stuff. You know, you pour some Coca-Cola on an open wound, it's painful, right? Can you imagine? This is going through this, and so these post-operative morbidity is very high. I've never seen a bunch of surgeons more averse to doing surgery than our esophageal cancer surgeon, because the patients do not do well. So your job is to prevent them from going through all these post-operative complications, because they need to drain this fluid, they have to deal with these infections all the time. So in summary, you do baseline staging. You can exclude surgery and put them into palliative options in 20 to 30%. At the end of therapy, you want to make sure there are no interval metastases. It can vary between 8 to 17% depending on the series. And then you can detect tumor recurrence, because it can alter your management when they come back 3 to 6 months after the end of therapy, because then you can direct it. It's either inflammatory, anastomotic leak, or local recurrence where you can give palliation for this patient. Any questions on esophagus? You guys see a lot of esophageal cancer patients? No? We see a lot of them. We see a fair amount of them. And it's becoming more common. That's why it's a problem. Gastric cancer may be more common. Gastric cancer more common here in Asia than in Western countries. Again, chemical H. pylori infection. We do a lot of the testing for eradication or presence of H. pylori. Again, smoking, obesity, low economic status, genetic mutation, polyposis syndromes. Again, we do all the usual round of endoscopic staging, multi-detector CT, MR, and even FDG PET-CT. Problem is symptoms are non-specific: dysphagia, early satiety, nausea, vomiting, gastric outlet obstruction, which is already usually very advanced. Most common symptom, abdominal pain and weight loss. So diagnosis is often delayed, and patients have advanced disease at diagnosis. Most of them are adenocarcinomas. So many classifications are used, but the simplest, widest is used is the Lauren classification, intestinal diffuse. Intestinal cancer, they kind of bulge out, expansile growth pattern with microscopic appearance similar to colonic mucosa. Diffuse are the Linitis type, diffusely infiltrate the gastric wall, desmoplasia, and inflammation. So it could be the bulging type. And then TNM staging, again, it's similar in the sense that if there's invasion of lamina propria or mucosa, subserosa, multicularis propria, subserosa or the serosa, visceral peritoneum, and adjacent structures, which is T4. EUS is really the best way to go in T staging, endoscopic ultrasound, 2-3 layer structure, and so you need a good endoscopist to assess T stage. A well-done CT scan can actually show the layers sometimes if you get lucky. The tumor is obviously here in the lesser curve and the detail is very good if you have a well-done diagnostic CT. So what are the patterns of spread? Contiguous via the ligamentous connection. So well-done abdominal CT is critical. If you're not an abdominal radiologist, it might not be a good idea to be looking at these cases because you might miss very subtle progression or extension of the disease along the various ligaments, gastrocolic, gastrohepatic, gastrosplenic, and hepatoduodenal ligaments. You look out for peritoneal dissemination. It is quite common, transperitoneal seeding to other organs, covering the liver, covering the peritoneum, these little millet seeds or sesame seed-like things. Lymphatic spread, perigastric regional nodes parallel to the celiac artery. And then liver, lungs, and bones, because there's hematogenous spread, it's systemic. It's very angry looking. So familiarity with the various ligaments and following the vascular structures for the distribution is actually good for adequate assessment of the extent and nodal stage of these patients. You can see this is just an example of gastrohepatic ligament involvement. You see that higher density over here. You can see here very subtle, not subtle, but very massive involvement of the gastrosplenic ligament. These are things which may not be as avid on FDG but it is something you need to be able to find very easily on the CT scan. Original nodes again. Number of nodes are what are used, up to 15 and 3. You can see here the bulky adenopathy, which you can see, so you can encompass them when you're trying to treat with multimodality therapy. Celiac nodes, left gastric nodes are seen here as example. M disease is essentially distant disease, M0, no distant metastasis. This is what it kind of looks like. You don't need to be an expert to know this is widely metastatic disease. It becomes a problem when it's only peritoneal disease, and unfortunately we do not see small volume peritoneal disease. What usually happens, we scan them, we say there's no peritoneal disease. They would still do a tap video and then take a look around and then take samples. And if it's negative on the synthesis, then they would proceed with opening the patient. Because you can miss very small volume disease. You only see the very bulky disease which you can see here. Here you can see no activity, very minimal activity in linitis plastica, poor uptake. Small volume disease, a lot of infiltrated disease blending in with the background activity. It's very difficult to assess. If it's positive, it's okay. If it's negative, you can't tell. So for here, TNM system still used, important prognostic indicator. Nodal station, different compartments, depending on the distance, like esophagus, and the number. You should have at least 16 nodes harvested at surgery to assess completeness of pathologic staging for gastric cancer. The key imaging points, they could be polypoidal or diffuse, sometimes alterated. Anywhere in the stomach, lesser, greater curvature. Presence of extraluminal extension in the adjoining ligaments, gastrohepatic, gastrocolic, etc., and direct invasion of adjoining organs. Number of nodes away from the primary are important. Mets are likely in the liver and peritoneal disease. We pay special attention to the nodes behind the head of the pancreas. You can easily miss those. Supraclavicular, because it's on the first slice of the CT scan or the PET study, as well as the periaortic, the more distal retroperitoneal nodes. Primary curative resection is great if you can find these patients. Early gastric carcinoma is very limited. It's very unlikely seen unless you stumble onto it. Gastrectomy with nodal dissection, when performed, is good, especially if the extent of adenectomy is good. You can get up to 16. D1 dissection, D2 dissection, and D3 dissection are forms of extensive removal of the nodes depending on the site of the primary. And sometimes you can still use surgery for palliation of intractable symptoms, not responding to conservative management. So recurrence is very common. 32% of patients who undergo quote-unquote curative resection face disease recurrence, likely to be identified within the first 2 years. It occurs locally in half and can occur in the peritoneum and distal site, very common. There are no reliable tumor markers. For us, if we do the PET study, it's essentially to see how limited the metastatic disease is, if it's amenable to any therapy, and to make them candidates for trial treatments for various things like chemotherapy, etc., immunotherapy or combinatorial therapy. CT scan, well-done diagnostic study CT scan is our modality of choice. FDG is okay, but a well-done CT study is what we do in our institution. And with that, I'd like to stop and take any questions if you have any for both esophageal or gastric cancer. Any questions? Yes?